You are now listening to Nailed It, the Orthopedic Surgery Podcast. You are now listening to Nailed It, the Orthopedic Surgery Podcast.
What I think we could do is, I know you have some cases that you have supplied us with. I think we can go through some of these, kind of tie all this together. Those that are listening, if you want to check out the YouTube channel, we'll post the cases there so you can actually see what we're talking about. But I will try to describe these x-rays as the best to my abilities that I can. But yeah, Dr. Grandizio, if we want to go through this, we can go through some of these cases and kind of I'll see how about this. We can try, and I can guess and say what I would have done, given my severely novice experience and not knowing much, and we'll kind of see if you agree, and then I guess we'll kind of go through what you did.
No problem. That'd be great.
Okay, let's see what we got here. So first one, 43-year-old female. It was a fall from a height, and we're looking at an AP and lateral radiograph from the elbow, which it looks like this shows kind of this shear fracture of this capitellum. Anything else that I see here? So I see this capitellum looks like it's kind of flipped up or displaced anteriorly or superiorly. Let's see. Don't see any. You can kind of see an outline of it here on the AP. I don't really see anything else. There's maybe a little widening in the ulnar humeral joint laterally, but otherwise nothing else that I would have picked up on these films. Let's see, what is the next one? A CT? Let's see.
I don't know. The next one might be what we
might be fixation.
Yeah,
okay.
Fixation.
So I mean, I think for this, I don't know if you need to do the whole, like the medial and lateral plating. It looks like kind of you just need to get something to get this capitellar piece in. So what we were talking about a little bit earlier, maybe this one I may do like the lateral Coker approach, either try to go through, between anconius and EDC versus split EDC. And I would try to reduce that, and possibly, I think there are a couple ways. I think some people may do like headless compression screws through the capitellum. Yeah, I guess that's what I would. Yeah. That's probably what I would do. I don't know.
I think that sounds very reasonable. Let's see
what we did. So okay, so this is.
I did have a CT. Sorry.
Oh, excellent. So we're looking at a CT scan that it kind of just shows it's displaced. It's kind of comminuted. It seems to be a little comminuted superiorly, but completely displaced capitellar fracture. And okay, so you want to take us through kind of what you did here?
Sure. So I think if you look at the lateral radiograph, it's what's often referred to as a double bubble sign. So there's two lines or two bumps. And if you go back to the CAT scan, I had put that in there to show that this is very common with the capitellar shear fracture. We refer to this as a capitellar shear fracture, but this is actually a capitellar and trochlear shear fracture. And so you can see in the image on the right, that extends into the ulnar humeral region, the region of the trochlea. And so in the AP radiograph, you don't really get a good sense of that, but the lateral X-ray is enough there to let me know that this is extending into the trochlea. And I agree with you, that does not mean that you necessarily have to do, a medial approach, but I think you need to know how much of the trochlea is involved, and if you can address this injury from a lateral approach. And so in this particular case, I did a lateral approach and was able to fix it with headless compression screws. I try to get fixation in two planes. And so the shorter sort of anterior to posteriorly based headless compression screw, and then one that goes from lateral to medial, almost like a rebar type construct. I think there's some biomechanical advantages to that, of getting fixation in two planes. The other thing I'll say about these fractures is that in cases where you have some comminution of the posterior cortex, or an impaction lesion, sometimes from the radial head, I think you can supplement this with a plate, with the idea of being able to get lateral to medial screw through your plate, and then A to P, headless compression screws. So I think a lot of different ways to go about fixing these in terms of construct and implants. But I think it's very important to recognize that a lot of these can extend into the trochlea and just aren't isolated capitellar shear fractures.
Okay, no, that's all excellent points. And so you're saying you may put a lateral plate and then put some screws to it just to make sure. I mean, put some screws through the plate just to kind of
Correct,
reinforce
particularly
it.
in cases where the posterior cortex on the lateral side
Oh, okay.
is not intact. I think it gives you some stability, some added stability to get fixation from lateral to medial.
And are these 2.7 screw? What size screws are these? Are these 2.7 screws here?
Those are 2.7 cannulated headless compression screws.
Ah,
There's
okay.
a variety of different screw types and sizes available, but those are 2.7 headless compression screws.
So you reduced it, had a K-wire, and then kind of drilled over the K-wire and put these screws in?
Correct. I try to get a initial K-wire outside of where I think my fixation will be, and then you can use the wires from the headless compression screw to hold your reduction provisionally, and then drill over. I think the other thing that's important in these is really to understand your lateral X-ray. We often talk about having the three circles if you get a perfect lateral of the distal humerus, and so those three overlapping circles are the central spool of the trochlea, the capitellum, and then the medial border of the trochlea. And so your widest circle, the widest diameter, is your medial border of the trochlea. Your capitellum is in the middle, and then the really narrow one is your central spool of the trochlea. So I think it's helpful, particularly when you're assessing your reduction and assessing your implant position, to kind of be able to critically assess what's what on a lateral X-ray.
Yeah. So when we're looking at this one, injury film, so it looks like we have this fragment here. I thought this was just that, but it was rotated.
Mm-hmm.
And then is there anything, I mean, maybe this little piece of comminution here, but is there anything else on here that you see that you would have picked up on that we may not be picking up on, or that I may not have picked up on?
No, I think you covered it. I mean, I think that double bubble sign, can clue you into there's a capitellar shear and potentially with extension into the, potential extension into the trochlea. And I know we had talked about this earlier, but this is a fracture that I routinely get a CAT scan on.
Yeah. Cool. All right. Well, let's see here. What do we have here? So we have next case. This is a 77-year-old female who was in a motor vehicle collision. Again, we're showing AP and laterals of the elbow, which shows this kind of this medial sided shear fracture, and it seems to involve intra-articular. So intra-articular looks like a type B, involving right into the kind of trochlea. So intra-articular piece right through the trochlea. This is displaced on our lateral. This seems to be, I think that's missing capitellum. So it looks like our capitellum is often displaced. And then that's what we have on the medial side here. Let's see. Is there a CT scan?
Yeah, there's a CT on this one.
All right, let's see. Oh man, yeah, bad injury. So CT scan just showing that it is a little bit more articular damage than I would have initially thought, as all this kind of posterior fragment. So for this,
it's like an old in training question with two oblique X-rays.
Yeah, I know. So for this, what I may do is I would probably do an olecranon osteotomy. I think I'd go posteriorly, do an olecranon osteotomy. See what you can do, see what you can see, reduce the capitellum, reduce the medial side. So I may do orthogonal plating on this. I think you can do both. I think you can either go orthogonal or parallel plating, but I would possibly think orthogonal because that posterior lateral plate, you can get some screws into that capitellum, and on the medial plate, you can kind of buttress that medial fragment. But here, let's see what we have here. Oh no, completely off.
I think that if this patient was 24, you make every effort possible to fix it. And I think there's a couple of things from the X-rays in this case is that, in the lateral, you get a sense that there's a shear injury to the capitellum and trochlea. And then I think much better appreciated on the CAT scan is the fact that this is a very low transverse fracture.
Yeah.
And so the combination of those two things in older patients, and I believe this patient's in her mid-70s, are an indication for a total elbow arthroplasty. And that's a whole, I think, a whole separate discussion. There's some classic articles and showing for common intra-articular fractures in patients over 65 that the results of total elbow may be better than ORAF. I think that even in this age group, if the fracture is able to be fixed, a C1, a simple intra-articular fracture, I would lean towards fixation over arthroplasty.
Okay.
If you run into a low transverse fracture, with shearing injuries, at least in my hands, that's not something that I think that I could get anatomically reduced and stable to allow for early motion. And so those are the fractures that in the patients in their 70s and their 80s that I lean more towards, total elbow arthroplasty. I think that that's, not a discussion or decision that's taken lightly. There are certainly complications with total elbow for fracture, and it's but I think that in that population and for this fracture, I think a better option than fixation.
Okay, so key things here: older elderly patient, this very low transverse fracture with the kind of those shear components, be pretty hard to get enough screw fixation distally into that fragment, and especially given her age, why total elbow was chosen in this patient.
Correct.
Cool, good case. Let's see. All right, here we go. 42-year-old females in a motor vehicle collision. This almost reminds me of those pediatric type fractures. But let's see. So we have an AP and the lateral of an elbow, skeleton mature individual. It seems to show the articular surface seems to be okay, but definitely get a CT on this. But it kind of shows this to the naked eye, to me, what seems to be like this partial articular fracture of the distal humerus, comminuted. Let's see, on the lateral, I mean, it's displaced anteriorly. Definitely to have a good neurovascular exam for this patient, but the joint itself doesn't look too bad.
No.
To me. Let's see. Do we have a CT on this? Let's see.
I don't.
Oh, boom. All right, let me try to. So for this, I probably would have done I'd probably go posteriorly. I think you could work through paratricipital windows for this. I don't think you need to do an electron osteotomy. And I would definitely put a plate laterally. I'd probably do parallel plating with this, and yeah, I think that's what I'll do. Let's see what we have here. Almost right, orthogonal plating. You want to take us through this?
This is interesting. This was a case actually of my early on at this was in my board collection period. So she had a non-displaced intra-articular split, and that's a positional screw across the fracture site. And again, my preference is for parallel plating. And in this fracture, I thought I would be able to get more fixation using a posterior lateral plate. And this is actually her x-rays at 6 months. She had a non-union.
Okay.
And I think there's a lot to discuss for this. So this was an atrophic, an atrophic non-union. And if you look, I ended the plate at different levels. And I think what I failed to do here was get adequate supracondylar compression. And so if you look at this, it's an extremely rigid construct. So there's multiple locking screws just distal to the fracture. Proximally on that posterior lateral plate, there's a lock screw just proximal to the fracture. And so this was at least in the metaphyseal component, a simple oblique fracture that was fixed with a gap without adequate compression. And in addition to that, it created an extremely low strain environment because there's rigid lock fixation kind of all over. And so that combination, gap, lack of compression, low strain environment, is a recipe for non-union.
Yeah.
And fortunately, she healed somewhere between 9 and 12 months from what I remember without any further any further intervention. So at this point, a delayed union. But I think it's often very easy to go back and say, oh, this was high energy and she's a smoker and this and that. But I think that early on, this was a technical failure of mine, and a case I learned quite a bit from.
And so if you're doing this again, if you had to go back and redo this, you would still keep the medial plate, but you do parallel plating for this. And then one of the things that you would say that you try to get that supracondylar compression. So you'd use a periarticular clamp to and you put it on the sides of both of these plates, and then you you loosen that screw and put another 3/5 screw in. Is that correct?
So yeah, and again, I don't think there are any issues related to the posterior lateral plate. I think a lot of people use that, and there's certainly a fine construct. I think if I was doing this again, I would have chosen parallel plating. I would have put a provisional cortical screw in the oblong hole in the shaft, and then compressed, got compression, through the fracture. Better than I did before getting the rest of my fixation proximally and distally. And so I think in this case it's important to get the supracollar compression before you get your definitive fixation, and you can do that with one screw in proximally in the oblique hole, and you can just take a clamp and compress through compress with the clamp.
Cool. And looks like probably we got one more case here. Last one here is 24-year-old female, and we're looking at an AP, and we have a coronal. I'm not a coronal. We have an axial cut of the distal humerus. It shows intra-articular fracture. It's very displaced. It's comminuted medially. So, I mean, for this is one I may do an olecranon osteotomy for this just to. It's somewhat simple. I don't know. I may start with the paratricipital and see what we can get. And then definitely a plate medially, given that comminution. That's kind of where we kind of need to put a buttress there. And then laterally, I guess you could either go with a posterior lateral or just you could go with orthogonal or parallel on this, but let's see what we got here. Okay. You want to take us through what you did here?
Sure. So I think this is a good example of exactly what you just said, that you can do the paratricipital and you can see if you can get it reduced and fixed. And if you can't, you can just extend and do olecranon osteotomy. It's not that much extra work. You never really regret doing it. But I think in this case, even with an simple intra-articular split, I didn't need it to get it reduced or fixed, so I was able to leave the triceps on. And so this is sort of a more classic example of the steps. So you start by reducing the articular segment, and that's a positional screw. Taking care not to compress because that'll narrow your trochlea. Positional screw. Get your medial and lateral plates on. Your single cortical screw in the oblong hole proximally. A couple of lock screws distally through each plate, and then you can get really good supracondylar compression, through each of the plate, and then finish with your, definitive fixation. And so this is, I think, a more classic example of parallel plating construct and the steps you would take to do this.
Awesome. And then one more here, 55-year-old male. And let's see, I gotta take what I'm looking at. So we have AP in the lateral. There seems to show. Gotta get my orientation here right.
Yeah.
So on the AP, or somewhat of an oblique, it looks like there's kind of more of a supracondylar fracture. I can't tell if it's impacted in.
I think very similar to the other one in that you can kind of get a sense of a non-displaced intra-articular split.
Yeah. And then you want to quickly take us through what your thoughts were on this?
I think very similar.
Very similar.
Again, I think even in these, you can start with the paratricipital approach. And then, if you need to extend, which in this case, I was able to get the articular surface reduced, without an osteotomy.